Hello and welcome. The number of COVID-19 cases are rising in India, over 3.46 lakhs or 346,000 now, 2,624 deaths. Now, these are the numbers we know. What we don't know is in many ways much more. We don't know how many potentially more cases there could be, whether those cases are there but not being tested, or even if being tested and maybe results not revealed. Secondly, the number of deaths. This is the more tricky part. The number of deaths, by going by all media reports, is much higher than what is being documented. The number of deaths could be because of COVID or may not be because of COVID. But either ways, we don't know any better. And the numbers in many cases in some cities are almost 10 to 15 times that is being revealed, particularly at the crematorium level by various municipal governments or urban local bodies. So the question or the series of questions are as follows. One is, when there are such huge data gaps in the middle of a raging pandemic like this, what does it mean? Secondly, what does it mean not just in the near term, but in the longer term, not just to people like you and me who are trying to understand how badly we are affected, but also to those who are trying to model and look forward and prepare public health responses for the future. The second is that how do public health professionals, particularly whether in government or out of it, try and make a case for responses in terms of infrastructure, medicine, medical facilities, and so on, given the fact that, once again, there are such data gaps in the system. And the last question that we want to address with our guest today is, what can we do about this? What can we do something at a policy level? Can we do something very differently? Can we use technology innovatively? So those are the three broad points that we're going to cover. I'm pleased to be joined by three guests: Dr. Giridhar Babu, Professor and Head of Life Course Epidemiology at the Public Health Foundation of India. Professor and Dr. Babu is a medical doctor who also has a master's in public health and a PhD from the University of California, Los Angeles. I'm also joined by Dr. Murad Banaji, mathematician and a senior lecturer in mathematics at Middlesex University, London, and he has a PhD in mathematics from there. Dr. Banaji, thank you very much for joining me. Dr. Babu, thank you very much for joining me. And finally, Rukmini Srinivasan, a data journalist who has a very interesting book coming up called Whole Numbers and Half-Truths: What Data Tells Us About Modern India. So that's something that I'm sure will use many of the things that we're going to talk about or have been talking about all these days as important case studies. Thank you all for joining me. Dr. Babu, why don't you start off first? So what does this mean? What the data gaps that we're facing, what are they, why are they critical, and what does it mean as things stand today?
Thanks, Govind, and it's nice to be with two experts in analyzing data and providing inferences to the public. So I have a very simple understanding of how to use data. We should use data for action. If we are not using the data, which will not only decrease the inequities and also ensures smooth provision of services, then there's no use of collecting such data. I'll just give you an example. So if state A has better data in terms of enough cases per million, and state B does not do that, we are actually disempowering the population by not detecting the infection when it is already present, by not subjecting them to the treatment, and by not giving them an opportunity to prevent deaths. So therefore, the inequities already exist in the community. But when you do not do justice to data collection and in terms of analysis and inference, you are actually causing more harm than doing any service to the people. So that is the first tenet of the discussion today I will take. The second is, any action that you need to take, you need to use the data in timely manner. So if the data is analyzed maybe after a year is over, or after for example, if the genomic sequencing data comes after the surge has already started, then it is not useful. If the genomic sequencing data is not matched to the cluster investigations to see how many people are getting because of a particular variant of concern, then it will not be useful. So it's not just collection of data and accuracy around it, it's also being timely. So I'll stop at that and would like to hear the thoughts of the other colleagues here.
Right. Okay. Dr. Banerjee, you want to go next?
Yeah, sure. First of all, completely second everything that Dr. Babu has just said about not just the data being collected, but also being shared in time, if it's to be used in a useful way. So speaking from a kind of point of view of a modeler, somebody who tries to look at past data and then do at least some prediction about what's going to happen next, where the disease is going to go. If you have good quality data, then you can construct models which have some hope of predicting and explaining what's happened. So for example, if we know how much the disease has spread in different places, then we might be able to predict what the effect of a second wave will be on those places. If we know which variants have been spreading, then we might be able to predict how fast the spread will occur. If we know how many people have died, then obviously that also acts as a very, very important indicator of how much spread there was. On the other hand, if we have, for example, between different states, vastly different levels of surveillance, then you're in a very complicated game, really. You're trying to understand, let's take the example of Maharashtra, which we know has been very badly hit in both waves of this pandemic so far, but we don't know the extent to which that's something actually specific to Maharashtra's demography, to its urbanization, to some other factors, and how much it's specific to the degree of surveillance in Maharashtra vis-a-vis perhaps some other states. So it's very hard to unpack the story of what's happening in one state, whether there are reasons why COVID is spreading faster or causing more deaths, without actually having some sanity checks on how good surveillance is of the disease. So once you've lost that basic data integrity, making reasonable predictions becomes extremely hard. And I think we've seen that with how out of their depth some of the modelers have been in terms of trying to predict what's going to happen with this wave. We've got a very wide range of different predictions, and I wouldn't blame the modelers for that. I would say, well, it's very hard. How do you parameterize your models? That means how do you actually accurately construct them in order to make predictions? And that's not to mention, of course, all the multiple other issues, such as the fact that it's a matter of basic natural justice that people's deaths need to be counted. You know, I'm talking about prediction and forecasting, but obviously there's also a matter of of justice and equity in terms of accurately recording the impact that the pandemic is having on different communities.
Okay. Rukmini, what would, according to you, would be the 2 or 3 biggest pain points when it comes to trying to understand data? And I noticed that you wrote for Guardian on the lines, or rather on the subject of the genome sequencing and the data for that, and the gaps, to the point that Dr. Babu was making earlier as well.
Right. So as someone who's not just looking at the data, but also, used to seeing the limitations of the Indian state in all its various forms, I sort of think of this at 2-3 levels. One is data that we would like, but has simply not been collected. So, I would be pragmatic about that. So, for example, sero surveys simply do not exist in large parts of the country. So, wanting to know about it is one thing, but hypothesizing about it is pointless. And, we know that overnight data collection is not going to start. So I think we need to be practical about the things for which data does not exist and just be clear about that. The second level is things for which data has been collected, but is either not very good or unusable or not being put out. So the not very good and unusable parts of it are where, you're seeing this great community coming together to try and put things together. So, Covid19 India.org, for example, exists because that data does exist, but it was simply not put together by the Indian government with all the data checks that it needed. Some of it is unusable either in format or for things like denominator issues. There's a nice survey that initially the Bihar government did about incoming migrants, and you were able to get some sort of indication of where from which source areas high positivity was coming. But I do understand that was not a perfectly done study, so it leaves you not very sure about how to use that data. And then there is the issue of data that's not being released, or as Dr. Babu said, data that's being released too late. We know that there's it's a real problem that the sero survey data, national sero survey data, is coming with such gaps. There's a whole lot of scientific research for which there isn't published data, although claims are being made for it. So that there's that universe of data which simply is not being shared, and that's a problem too.
Right, and you mentioned data that's not being released at all. What's the one set or data set that stands out the most for not being released?
We've been told about surveys that some states have done, which they've not put out. So information that they did collect, but they haven't put out. So it's the very fact that it's not been put out. I mean, that largely tells you that there's very little you can say about it. But multiple states
Right.
have told me off the record that they've done, for example, audits of, well, this is not even off the record, audits of the deaths of the state. We sent RTIs to multiple states asking for these audit committee reports, and we didn't get them. So that data is simply not being revealed. And I would say even the PM Cares Fund is in that category of information that we do need, that we're not getting the data from.
Right. Okay. So, Dr. Babu, so if we were to look at now the 3 or 4 areas that are crying for addressal, and then we'll come to other areas, what are they? And in addition to the fact that there is an element of natural justice that Dr. Banaji referred to, what are we losing out on? Because in many cases, in India, for instance, nothing happens, or if things get solved by themselves, then we tend to forget about it. And how do we convince such people that, this is what you're losing out and there is no way you're going to get it back, because maybe once you've not collected the data, then you've lost your opportunity to ever collect that data.
Was it for me?
Yes.
Okay. Yeah, see, I'll just give you an example, Govindra. Now, if you look at the top 5 states in terms of the cases per million, it'll probably be around 21,000 cases per million. And if you go to the top bottom 5, it'll be around 2,000 per million. Now, where is 2,000 per million? Where is 20,000 per million? This is like 10 times difference between the states that we are looking within India. So, to answer your question very specifically, by taking this point, when we review a program, we should ask the right question. What is the right question? Why are you not detecting enough cases in your population? Why aren't you not doing proper testing? Why are you not using syndromic approach? Instead of that, if you are asking the question, why does your state have more cases? Now you see the entire focus is shifted elsewhere. Now, this is the irony of public health implementation. A state like Delhi or Karnataka or Maharashtra, they have, let's assume for a second, not getting into any political ramifications, let's assume that they have good governance. They'll do better testing, they'll have more cases, and they ask for more help. They'll say, we need more beds, we need more oxygen, all is fine. And we are also saying, you have got problems, so let me review and then probably I'll give more support to you. On the other hand, you are not concentrating on areas where people are not getting tested. They're sent back. We are not treating them. Probably there are more deaths. So you see the kind of difference just because the wrong question being asked. And this is not unique to COVID-19 control. This has happened in every public health program. I worked in an organization called National Polio Surveillance Project. Till WHO started working on it, all the states were reporting poor number of polio cases. But when we started the work, Uttar Pradesh and Bihar had the highest number of polio cases till we eradicated. How did it happen? It happened in the same system, but by taking over the work of data collection and inference to an independent and autonomous agency within the entire governance structure. We need to evolve mechanisms which takes this data collection, inferences for action out of this general management of things. And this is purely technical work. I don't think any administration mechanisms will be able to tackle this.
Right. Okay. And we'll come to that in terms of solutions in a moment. Dr. Banaji, I guess some of us have seen what you're trying to do with existing data. So now, what's the the concern in here? Because you're using data which you yourself are not sure about and trying to model. So will the modeling, whether it comes from the rise of number of cases or deaths, will that figure change, likely to change? Is there a sort of moral hazard in doing all of this in itself?
Well, I think the main thing is that you have to take account of the uncertainties when you're doing the modeling. You have to build that into your modeling approach, because otherwise you risk saying very wrong things. And you have to constantly update what you're doing. So, I mean, modeling is not just taking data and using it. In some ways, it's also commenting on the data at some point. So, for example, when I was tracking Mumbai's epidemic in the early days, we're talking about during March, April, May 2020, there were certain very clear and very stark trends which started to appear. And the question which arose for me as a modeler was whether those trends were there were trends in fatalities. In particular, the city was not generating the number of fatalities based on early data that the models were predicting. And the question arose, why is this? Is this because deaths are not being recorded in the city? Is it because disease is spreading in a different population where there's less fatalities occurring? Or is it for some other reason? I explored those issues in a couple of publications at the time. And I gave space to all the different possibilities, but I said that I believed that there were deaths which were going missing in the city that were off the record, so to speak. And then later on, this was vindicated. There was a massive reconciliation where some 1,700 deaths were added back into the city's toll. Now, the problem with that episode, I mean, I suppose it's nice to be vindicated when you say that, yes, deaths are going missing, and then later on it turns out to be true. But the problem is, we now don't really know when those deaths occurred. So when we're tracking the early trajectory of the epidemic, when it was raging in the slums of Mumbai, we don't know exactly who and how badly people were being affected by this. And when it comes to trying to predict what's going to happen and trying to understand Mumbai's second wave, that gap in our knowledge is actually a huge gap. It's a very important gap. So even though there was some reconciliation, there was an improvement, and that was a very positive thing. And I do feel that Mumbai's data has improved a lot since those early days. It's still left a kind of shadow in attempts to understand what's going on with the second wave. Obviously, since then, we've had a lot of sero-survey data. We've had a variety of other kinds of data which have helped to inform on the city's epidemic. But the broad point is that when you have this poor quality data, like if you look at what's happening, say, in Gujarat at the moment, where there are these huge reports of death undercounting taking place, and in Madhya Pradesh as well, this is going to leave a shadow in terms of understanding how the epidemic has actually traveled through these states, and what are the vulnerabilities for future waves, and perhaps also questions about how vaccination ought to be targeted in the future. So it leaves very practical gaps in our knowledge.
Right, and vaccination is something that is upon us, and I'll come to that in a second. Rukmini, you've written about undercounting, and you've looked at Kerala and Maharashtra, and you were able to show that there was overcounting and undercounting. So now, is this only because you have data, or these states were revealing more than others were? And if these states were, I mean, this was the position in these states, what could it have been in any other state or a large populous state that was not giving out such data?
So I think from the two, Kerala and Mumbai, the data that we have, it isn't really able to give us a wide enough picture for the rest of the country. Because in Kerala, for example, which did not find an increase in all-cause mortality in 2020, which is a surprise. I think one possible sort of political way of looking at it would be for the state to praise itself and say that it did a good job. But even those in the administration of the state told me that they did not feel confident of the data, and they would not take this as proof of having done particularly well. And they do think that future surveys or going over the data or an audit in the future would be a good idea. In Mumbai, not having a cause by cause breakdown of the data is a problem, because as we know, accidental deaths are significant in Mumbai. Both of these are very specific regions, and generalizing about them becomes difficult. There's also an attempt to use, the CMI's database, which is not actually intended to look at health data, but in the absence of other sources, this is what some have looked at. And just to, speak to Murad's point earlier about the crematoria data as well. I think a lot of time last year was spent in sort of polarized arguments about how many deaths were from COVID or not. And I, see the point about how epidemiologically and from a public health perspective, it is very important to figure out how many were from COVID. But I think what we're seeing right now, and that's coming out from all the news reporting from burial grounds and crematoria, is that there is an increase in people dying, and maybe at this moment we do not have the infrastructure, or we're going to need a small survey to tell us how many of these were COVID deaths. But at the very least, I think they do seem to be saying something about all-cause mortality. Unfortunately, that data for India last came out for 2018, and I really do think that politicians or whoever it needs really needs to make a push to the government to be doing either a sample survey or something of the sort to figure out all-cause mortality for 2020 and this year as well. I mean, as the year is going, it's really the all-cause mortality that personally bothers me the most.
Dr. Babu, I mean, on the dashboard, what is it that stands out most for you, or for its absence, perhaps, if not its presence?
No, definitely the excess deaths, which are the result of an epidemic, is of great interest to epidemiologists, and also to understand how much priority should be given for such control programs over others. But at the same time, we should be mindful that whatever we do in terms of understanding the data, we should build robust systems which will take care of a long-term perspective, not just for one small program. Again, if you were to have a stronger surveillance platform which collects the data and then analyzes it in a timely manner, and then you add another program to it, it will not be a burden. But the India's premier integrated disease surveillance program is one such program which had this ambition of integrating all the other surveillance programs. But Govind, more people will be surprised. There are at least 8 or 10 vertical programs, and some of them collect data which are either duplicate or redundant. As a result, all of this load gets onto the basic health worker in the field, and they'll have to collect the same data for different vertical programs. I think it is time to reorient the systems towards data that is one, horizontal integration, which is feasible within the context. Second, it should have the flexibility to onboard some of the pandemics or any other short-term health programs that we do. So instead of picking on one indicator, I would say we need to build systems.
Right. Okay, and I'll come to that in a moment as we go towards the sum up. Dr. Banaji talked about vaccinations and that being imminent, and how the lack of data is affecting a likely vaccination strategy. Your thoughts on that, Dr. Babu? So
now, regarding the vaccination, there's a lot of data that would like to know. One, at least in the initial phase, we wanted to know, because one vaccine was permitted under clinical trial mode. We wanted to see what kind of effects are there after taking that. There is these mechanisms of building trust in community, which are very important. And that comes only from transparency in data. Most times, I have worked with several governments for several programs. It's not that the policymakers probably don't want to share. They are scared that once an adverse event is known to the community, maybe people will not turn up. So this comes from a very paternalistic approach of let me take care of the society, that being the main driver. There are other issues in why the data is not shared, but I think this is time to reorient our systems, and this will also require people who manage the data to be free from people who run the program or who make the administrative decisions. This is as important as getting a few data indicators set right.
Right. Okay. And I thought that many of the flagship programs that we have also have dedicated budgets for monitoring and data collection, don't they, Dr. Babu?
We want the data to be collected for every program, but then the resources provided for data collection is very meager. I mean, there is no separate head in most programs for data collection. I'll just give you a comparison. The NCDC, National Centers for Disease Control, which is the place for looking at data in terms of IDSP and all the other programs, it gets minuscule budget out of the entire health budget, The equivalent Centers for Disease Control in the US gets around 650 million, and the tasks are same. So you would want to understaff, under-resource, and then undervalue the kind of people who are engaged in data collection, inference, but then you would want them to overperform, especially during pandemics, but also in other routine programs.
Right. Dr. Banerjee, you, I'm sure, have looked at other countries. England is a good example in itself, that you are now emerging from a lockdown and things are freeing up. What did data play, or the role of potentially better data collection and therefore better modeling play in this? And in general, would you like to contrast India with any other international examples, and either what we could either learn or even relate to?
Well, I haven't tracked the UK's epidemic as closely as I've tracked India's, but there are a few kind of stark contrasts. I mean, I think that there were a lot of things which were done wrong in the UK as well. I think that some of the issues are quite general. For example, the tendency to spin data rather than to present it transparently. But one of the plus points is that some of the bodies which have been handling data in the UK are really quite independent of government. And so there are a couple of programs which I think would have been really fantastic to see in India. One is there's been very regular surveying of the population to decide on incidence, how much COVID-19 is there in the community at the moment. So this is surveying of different kinds, surveying for active infection via PCR tests, RT-PCR tests, surveying for antibody levels, so that you've got a kind of sense of how many people have at least recently had the disease. So you had a kind of tracking mechanism. It's easy to pick out with that when you start to see incidence levels rise. So for example, when you had a new variant starting to spread, it was quite clearly, it was quite early, quite soon visible in the data that something is going on. At that point, it might not have been known exactly what, but that something was going on. You've had a high level of genome sequencing, so it was possible to track the rise of the new variant, B117 as it's called in the UK. And you also had, as vaccination was rolled out very, very quickly relative to many other countries, you were able to track the effects that vaccination was having and how successful, in fact, it was proving to be at bringing down severe disease and then ultimately also infection levels and transmission. And we would like in India to be able to say, although vaccination has been limited, the fact that it's been targeted at those groups which are most vulnerable to severe disease, it's having an impact. It's bringing down deaths. The trouble with this is that in the middle of a raging wave, it's extremely hard to say, actually, yes, vaccination is working and is bringing down deaths, although I believe it is. But the kind of data that you need to be gathering is very specific to be able to say that. You need to be very carefully tracking people who have been vaccinated and to see how many of them actually test positive, and to see ultimately if any of those cases are severe disease. I mean, people who've been vaccinated sufficient time ago so that they are protected from severe disease. Instead, what we saw, as Rukmini revealed really nicely in IndiaSpend, was you saw essentially a very big spin operation claiming that there are very few breakout infections occurring in people who are vaccinated. The intention was probably good, to increase positivity and confidence in the vaccines, but it was done on the basis of completely poor quality data analysis. And in fact, I think some clear dishonesty, because it wasn't being tracked until early April, the necessary data. So you can't build confidence in vaccination without actually properly doing it, tracking what's happening. And I would love to be able to say with confidence that the vaccination drive is having a positive impact in India. Right. And I don't understand why there isn't more of an effort to actually specifically gather the kind of data that you need to make that claim.
Right, right. So let me look forward now, and last question to all of you, and let me come back to you, Dr. Banerjee. What can we do today? Macro policy intervention, micro policy. When I say micro policy, I mean it could be urban local bodies, which are also critical, and we have large urban local bodies, agglomerations in India. What could we do or should we do at this point to respond right now, if we can, and for the near and the long-term future in the context of data?
That question for me, or who are we
Yes,
starting with?
yeah, Dr. Banerjee, for you, and then I'll go. I'll go
Okay.
to Rukmini.
So at the moment, the problem is that it's a firefighting exercise. The wave is so overwhelming. I mean, it's a tsunami of cases. There are hospitals being overwhelmed. There is almost certainly a huge rise in all-cause mortality that Rukmini talked about. So not just in COVID deaths, because once hospitals are overwhelmed, then people with every condition risk an avoidable death. So it's very difficult to talk about what data should be collected at the moment when really all resources need to be poured into just slowing down the spread of disease right now in order to then be able to try to control the wave. So I think the first priority at the moment is obviously just to slow the spread. And we understand the basic mechanisms by which you slow the spread of COVID. We have a lot of experience now with that, in terms of what works. I won't go into all the different kinds of mitigation, but that has to be the kind of broad principle. And obviously, we also need to be continue vaccination as quickly as possible. This needs to be a key priority at the moment, increasing the pace of vaccination. I do feel that it's important to focus on those who are most vulnerable until you've got extremely good coverage in those groups. So to focus on people who are elderly, on people with comorbidities, because we shouldn't yet be seeing vaccination as a way of bringing down the spread of disease. We should be seeing it as a way of stopping severe disease and reducing mortality. And then once we've achieved some success with that, then we can talk about reducing transmission and slowing the spread of disease. In the longer term, I mean, looking forward, I think that all the kind of excess mortality that we're seeing right now, there will need to be surveys to determine the extent of that, because it's not just it's partly a matter of understanding what's going on. So when you see the reports coming from Gujarat and Madhya Pradesh, and I'm sure they will spread to many other parts of the country, when you see the huge and devastating kind of tolls and you see the obituaries pages in local newspapers, you have to say, well, we need to survey to at least track what happened during this wave. And then, of course, an understanding will come about why disease spread so very fast, why health systems were so quickly overwhelmed, and hopefully all of that understanding will lead to some changes in the future.
Right. I mean, and I don't know if that's the right example, but we almost need a 9/11 commission intensity of investigation into what happened and why it happened. Rukmini, from your point of view, as you look ahead, where do you feel we could devote our resources from a macro policy point of view? Really looking several years ahead rather than right now.
Well, one is I think genomic sequencing both now and for the future is going to be hugely valuable. And again, I think one of the problems is when you're very razor focused, it's sort of putting out one fire and then seeing a bigger one, which is that first the issue was that there was too little genomic sequencing. So now there's a little more. But the thing is, we don't know anything about anything about the sample. So, for example, I saw some reporting from the UK, for example, that an inexplicably large number of the Indian samples from March of this year were from West Bengal. Now, that has an impact on what you're going to find from it. So we need, much better transparency about what the overall Indian sample is and why. What is the strategy of what samples are going. And for the future, I can't imagine that. I can just picture how more genomic sequencing is going to be of great value. Secondly, I think we need better health systems for rural areas and smaller cities. So, we've had to rely on the hard work of local reporters to understand what's going on in most other places. The sort of graphs that Murad has been able to produce showing differential spread in slum and non-slum areas or parts of the city. It's great that we have it for Bombay, and tragic that we don't have it for most of the rest of the country. We don't have anything about severe disease or hospitalization in most of the country. So all that we rely on is reporters standing outside hospitals telling us what's going on there. And finally, for the future, the main thing I would want is a culture of transparency and of data integrity. So, being clear about the data you have, the abilities and the capacity you have to produce that, and producing data without spin. That's about as much as I can ask for.
Okay, and those are the biggest asks. Thank you, Rukmini, for that. Dr. Babu, so if you were to pick up on Rukmini's point as well, that, and as you also look ahead in terms of what we could be focusing on, if you don't want to reveal the numbers, if you want to, put up scaffoldings and corrugated sheets to ensure that people don't look at crematoriums, there is a more fundamental problem. So how do we address that, even as we try and build the systems that you spoke of, or integrate many vertical data collection methods and maybe use technology more efficiently there?
Yeah, I think Govind, there's some brilliant points discussed throughout the interview. If I can sum up, we need to shift from a policy-based evidence generation to cater to how the policy works to evidence-based policy implementation. So that's a different. Right now, we are trying to show data that justifies what the policy actions are. That's not what we should be doing. We should have the evidence, and evidence should dictate what policy we should be able to implement. In order to do this, we need to generate timely, reliable, and disaggregated data at every level. So that's the first ask. The second thing is in terms of changing the culture. Right now, there is at least some kind of punitive actions taken if somebody reports a case or somebody reports a death. From that, we need to encourage data for decision making at every level. And this is not an easy thing that comes to everybody. Once you have to change the entire mindset and culture, we have dealt with this in several programs, and this can be done. And this is definitely very important right now. And finally, we have enough data in different systems. So, for example, there is death data collected in vital statistics. There is also National Cancer Registry. Once we need to combine all of this, the approach has to be multi-sectoral. So, just collecting data from one department and one arm is not going to be work. The dashboard has to be for Government of India, which is all of society approach, and that should include all the sectors involved. And this requires phenomenal engagement of software developers, people who are in public health, people who are in social sciences. And this has to be a reform by itself. It can't be patchy. It can't be isolated. It can't be fragmented. So that culture, that approach, that perspective has to happen now. So pandemic has only made us realize how vulnerable our data systems are. But this vulnerability continues throughout for all the other programs. At least now we have to make a decision and say, okay, let's build.
Right.
We have the best software companies also in India. So why not begin from there?
Right. Thank you so much, Dr. Babu. It does seem to be that maybe some of the solutions or answers will be found in Bangalore, where you are, or closer to Bangalore than in Delhi, where some of the larger sort of top-down policy decisions are taken. Dr. Murad Banaji, Rukmini Srinivasan, and Dr. Babu, thank you very much for joining me. Do hope to continue this conversation as we try and understand and fix India's big data gaps. Thank you.
Thank you.
Thank you.